Good morning. We're about to begin. Raise your hand if you're able to hear me clearly. All right. This morning, we'll be looking at obstetrics and neonatal care. So we're actually going into module 8, special population, which consists of, I think, 4 chapters: obstetrics, obstetric emergencies, pediatric emergencies, geriatric emergencies, and patients with special challenges, which I had previously sent a link to a recording for that particular chapter, or a link to a lecture for that particular chapter. Right, let's get into it. All right, introduction. Most deliveries occur in a hospital. Occasionally, the pregnant woman is unable to get to a hospital. You must then decide whether to assist delivery on scene or transport the patient to the hospital. So you must be able to facilitate a field delivery or recognize when a field delivery cannot be avoided. Anatomy and physiology of the female reproductive system. The female reproductive system includes the ovaries, fallopian tubes, the uterus, the cervix, vagina, and breast. The ovaries are 2 glands, one on each side of the uterus, similar in function to the male testes. Each ovary contains thousands of follicles, and it's actually 200,000 follicles. And each follicle contains an egg. So a female is born with all the eggs that she will need in her entire life. Ovulation occurs approximately 2 weeks prior to menstruation. So the follicle matures, so develops, an oocyte is formed. The oocyte eventually becomes an ovum, and it's released. As it travels, if it is fertilized, it implants into the wall of the uterus, and there it will develop into an embryo, eventually a fetus, and eventually delivery. If it's not fertilized, then it breaks down and it is removed via the menstrual cycle. The fallopian tubes extend out laterally from the uterus, with 1 tube associated with each ovary, and they alternate. So if this month it was the left ovary that released an ovum, then next month it will be the right. Fertilization usually occurs when a sperm meets the egg inside the fallopian tube. Fertilized egg continues to the uterus, where, if implantation occurs, it develops into an embryo and then a fetus and grows until the time of delivery. The uterus is a muscular organ that encloses and protects the developing fetus as it grows for approximately 9 months. It produces contractions during labor. It helps push the fetus through the birth canal. The birth canal is made up of the vagina, which is the upper portion. Sorry, not the upper portion, the lower portion. the lower third. So the birth canal is made up of the vagina and the lower third of the uterus, which is called the cervix. So the vagina is the opening, the cervix is the passageway. Right, so if you look on this diagram, you can see where the vagina is, and you can see where the cervix is as well. The vagina is the outermost cavity of the female reproductive system, and it forms the lower part of the birth canal. It completes the passageway from the uterus to the outside world. The perineum is the area between the vagina and the anus. It's an important area to be familiar with because it can tear if the delivery is explosive. So if it's an explosive birth or if it's rapid, it can tear the perineum, and that can cause a lot of bleeding. The breast produces milk that is carried through small ducts to the nipple to provide nourishment to the newborn once it is born. Early signs of pregnancy in the breast include increased size and tenderness. The placenta, which develops in the 4th week of the embryonic stage, is basically the lifeline for the fetus. So it acts as the liver for the fetus. It produces antibodies. It acts as the fetal lungs. It transfers nutrients and remove waste. And as I say, it's the lifeline. So the placenta attaches to the uterine wall and connects to the fetus by the umbilical cord. And the umbilical cord has 3 vessels, 1 vein, 2 arteries. Arteries move blood away from the fetus to the placenta, and the veins carry blood from the placenta to the fetus. Anything ingested by a pregnant woman has the potential to affect the fetus. So nutrients, oxygen, waste, carbon dioxide, toxins, and medications. The mother take these, it can affect the fetus. After delivery, the placenta separates from the uterus and delivers. The umbilical cord is the lifeline of the fetus. The umbilical vein carries oxygenated blood from the placenta to the fetus, and the umbilical arteries too carry deoxygenated blood from the fetus to the placenta. The fetus develops inside a fluid-filled bag-like membrane called the amniotic sac. It contains 500 to 1,000 ml of amniotic fluid. It helps to insulate and protect the fetus. The fluid is released in a gush when the sac ruptures, usually at the beginning of labor. Now, during the gestational period, which is usually 38 weeks of gestation divided into 3 trimesters, and it's calculated from the female last menstrual cycle. During the development, some changes will occur to the system, and you need to be familiar with these changes. So many normal changes occur in the body that are not all directly related to the reproductive system. So the pregnancy will affect the respiratory, cardiovascular, and musculoskeletal system. Hormone levels increase to support fetal development and prepare the body for childbirth. As the fetus develops and grows, the uterus also grows. As the size of the uterus increases, so does the amount of amniotic fluid. The uterus and organs are shifted from their normal position. Rapid uterine growth occurs during the second trimester. As the uterus grows, it pushes up on the diaphragm and displaces it. Now, if the diaphragm is being pushed up, then the respiratory capacity is going to change and the patient is going to develop a rapid breathing rate with decreased minute volume because the diaphragm is being pushed up. So they're going to breathe faster, but the minute volume is less. Blood volume gradually increases, allow for adequate perfusion of the uterus, and it prepare the body for blood loss during the childbirth process. The number of red blood cells is going to increase, the speed of clotting increases, the patient's heart increases up to 20%. So you may see tachycardia for a pregnant patient, and it's perfectly fine. In the third trimester, there's an increased risk of vomiting and potential aspiration following trauma. And this is due to changes in the gastrointestinal motility and the displacement of the stomach upward. Changes in the cardiovascular system and the increased demands of supporting the fetus increase the workload of the heart. Not all women are healthy when they begin pregnancy. Cardiac compromise is a life-threatening possibility. Now, weight gain is gonna occur, and this is normal. They can gain up to 27 pounds. Weight gain will challenge the heart, and it's going to impact the musculoskeletal system as well. Their joints become more loose and less stable, so their balance can be affected, and they might be prone to falls because their center of gravity is not the same anymore. So changes in the body's center of gravity increases the risk of slips and falls. So that's the normal changes. Let's look at some complications of the pregnancy. Most pregnant women are healthy. Some may be ill when they conceive or become ill during the pregnancy. Use oxygen to treat any heart or lung disease in a pregnant patient. They can develop gestational diabetes, or they can have diabetes before the pregnancy. So it can be as a result of the pregnancy, or they can have it before. So gestational diabetes develops during pregnancy in many women who have not had it previously. Gestational diabetes usually resolves after the delivery, but they can have the condition permanently, so they can permanently become a diabetic after. Treatment is the same as for any other patient with diabetes: diet, exercise, or insulin injection. However, what you need to keep in mind is that with a diabetic mother, the baby is going to be big. So she's going to have a big baby. And if it's a big baby, then the risk for perineal tear is high. So these babies tend to be big. Gestational diabetes, pregnant deliveries. The mother can develop chronic hypertension or develop hypertension after the 20th week of gestation. This is pregnancy-induced hypertension or preeclampsia. So it's either referred to as preeclampsia or pregnancy-induced hypertension. Now, chronic hypertension can interfere with the growth and development at of the fetus. It can affect their liver and renal function. It can lead to pulmonary edema in the mother, and it can lead to life-threatening grand mal seizures. So preeclampsia is pregnancy-induced hypertension. Can develop after 28 week of gestation. Signs and symptoms include severe hypertension, severe or persistent headache, visual abnormalities, swelling in the hands, feet, and anxiety. So the pressure goes up, that's a key one. They will have edema, that's a common one, and protein spills out in the urine, which is quite common as well. You're doing a urine analysis. Now, if the preeclampsia is not addressed, it will lead to eclampsia. So if the pregnancy-induced hypertension or preeclampsia is not managed effectively, it will lead to eclampsia, which is where they start to have seizures as a result of the elevated blood pressure. To treat seizures caused by eclampsia, lie the patient on their left side, maintain their airway, administer supplemental oxygen if it is necessary. If vomiting occurs, be prepared to clear their air passage, provide rapid transport, and request ALS. If these seizures continue, they will need medication to stop the seizures, which is magnesium sulfate. Transporting the patient on her left side can also prevent what we call supine hypertensive syndrome. So when they get close to full term, if they are placed in a supine position, it can obstruct the venous return and cause a drop in their blood pressure. And you don't want them to develop hypertension because the body is going to try to preserve the mother and not the fetus. So supine hypertensive syndrome is caused by compression of this descending and inferior vena cava by the pregnant uterus when the patient lies supine. So this will lead to hypertension. Now, bleeding. Bleeding can be observed in various stages of the pregnancy. It can be first trimester, it can be second trimester, it can be third trimester. Now, internal bleeding may be a sign of ectopic pregnancy, and this will be common in the first trimester. So this is a common cause of life-threatening bleeding in the first trimester, ectopic pregnancy. An ectopic pregnancy means that the fetus is developing outside of the uterus. So it's anywhere outside of the uterus. A common place for it to develop is the fallopian tube, and it can get to a size where it causes the fallopian tube to rupture, which leads to excessive blood loss, life-threatening bleeding. So this is definitely an emergency. So it's a leading cause of maternal death in the first trimester, right? The leading cause of maternal death in the first trimester is internal hemorrhage following a rupture of an ectopic pregnancy. So the ectopic pregnancy is very common in the first trimesters. Consider the possibility in a woman who has missed a menstrual cycle and suddenly start to complain of acute severe pain in the lower abdomen. Hemorrhage from the vagina that occurs before labor begins may be very serious. It may be a sign of spontaneous abortion or miscarriage. And an abortion is when the fetus is released prematurely from the wall of the uterus before 20th week of gestation, right? And that is more common in your second trimesters. They can have what is referred to as placenta previa, and they can have placenta abruptia. So they can have abruptia placenta, which the placenta separates prematurely from the wall of the uterus, or they can have placenta previa, where the placenta is actually developing at the vaginal opening. So it's blocking the exit point for the baby. Placenta previa and placenta abruptia is going to be common in your third trimesters. Right now, an abortion can be spontaneous or it can be elective. So it can be a natural thing that occurred. Well, I don't even like to use the term natural. Or they go to a doctor and have them do it. Elective. So this would be placenta abruptia. And placenta abruptia is very common with trauma. So trauma is the most frequent cause of placenta abruptia. It's very painful, and they can lose a lot of blood from this issue. Placenta previa, they are not going to be complaining of any pain or discomfort. It becomes an issue when the baby is ready to come out. So when that fetus is ready to be delivered, that's where it's going to cause complication for placenta previa. Now, abortion, the passage of the fetus and the placenta before 20 weeks. It may be spontaneous, or it is induced or elective. Most serious complications are bleeding and infection. Infection is very common, especially in Jamaica, because there are a lot of elective or induced abortions here in Jamaica, and sometimes all of the fetus or all of the placenta is not removed, and it can lead to infection, and it can lead to septic shock. If the woman is in shock, treat and transport her promptly to the hospital. Now, abuse. Pregnant women have an increased chance of being victims of domestic violence and abuse. Abuse increases the chance of a spontaneous abortion, premature delivery, and a premature delivery means the baby develops, the fetus delivers after, what's the range again? I think it's after 27 weeks of gestation, but before 38. Somewhere within that range. It's going to be before they reach 38 weeks of gestation. I can't remember the exact numbers right now. I need to double check that. Right, that's a premature delivery. Low birth weight, they're under 5 to 6 pounds. The woman is at risk from bleeding, infection, and uterine rupture. Use a calm professional approach. Pay attention to the environment for any signs of abuse. Talk to the patient in a private area away from the potential abuser if possible. Substance abuse. Effects of addiction on the fetus include So if they are abusing drugs, it can cause a premature delivery, can cause low birth weight, can lead to significant respiratory issues for the newborn, and it can lead to death. Fetal alcohol syndrome describes a condition of infants born to women who have abused alcohol. Pay special attention to your safety. Wear eye protection, a face mask, and gloves at all times. Look for clues that you are dealing with an addicted patient. The newborn will probably need resuscitation. Special considerations for trauma and pregnancy. With a trauma call involving a pregnant woman, you have two patients, the woman and the unborn fetus. Trauma to a pregnant woman may have direct effects on the fetus, and once her body starts to go into shock, her body will try to preserve her, not the fetus. Pregnant women may be victims of assaults, motor vehicle crashes, shootings. Pregnant women also have an increased risk of falling. Pregnant women have an increased amount of overall total blood volume, and they have a 20% increase in their heart rate. They may experience a significant amount of blood loss before you can actually see any signs of shock because of their blood volume, increase in blood volume, and the increase in their heart rate. So be mindful of that. The uterus is vulnerable to penetrating trauma and blunt injuries. When a pregnant woman is involved in a motor vehicle crash, severe hemorrhage may occur from injuries to the uterus. Trauma is one of the leading causes of abruptial placenta, can produce a significant amount of blood loss, and it is extremely painful. Common symptoms include vaginal bleeding and severe abdominal pain, and they will tell you that they don't feel the baby moving. They can't feel the baby moving anymore. Improper positioning of the seatbelt can result in injury to a pregnant woman and the fetus. Carefully assess a pregnant woman's abdomen and chest for seatbelt marks, bruising, and obvious trauma. Cardiac arrest, your focus is the same as with other patients. Perform CPR and provide transport. And I have mentioned before things that you would need to consider if they are close to full term, right? We have to consider pushing the abdomen, the fundus to the left to ease pressure off the venous system. We may have to consider elevation of the CPR board or stretcher to shift the diaphragm down. So there are some things that you need to consider. Notify the receiving facility personnel that you are en route with a pregnant trauma patient in cardiac arrest. And even if you think that the mother is not gonna make it, doing CPR can preserve the fetus until cesarean section can be performed. Assessment and management, your focus is on the woman. Suspect shock based on the MOI. Be prepared for vomiting and aspiration. Attempt to determine the gestational age to assist you with determining the size of the fetus and the position of the uterus. Follow these guidelines when treating a pregnant trauma patient. maintain open airway, administer high flow oxygen, ensure adequate ventilation, assess circulation, transport the patient on her left side. Now, cultural value considerations. Cultural sensitivity is important. Women of some culture may have a value system that will affect the choice of how they care for themselves during pregnancy and how they have planned the childbirth process. Some cultures may not permit a male healthcare provider to assess or examine a female patient. Respect these differences and honor requests from the patient. A competent, rational adult has the right to refuse all or any part of your assessment or care. Now, teenage pregnancy, which is very common in the United States, and it's also very common here in Jamaica. The United States has one of the highest teenage pregnancy rates in the world. Pregnant teenagers may not know that they are pregnant or may be in denial. Respect the teenager's privacy, assess and obtain her history away from her parents. Now, patient assessment. It's the same patient assessment with a few considerations. Childbirth is seldom an unexpected event, but there are occasions when it becomes an emergency. Dispatcher usually asks simple questions to determine whether birth is imminent. Premature contractions may be caused by trauma or medical conditions. Scene size up, scene safety. So take your standard precaution, gloves, eye, and face protection are a minimum if delivery is already in its initiation stage. So gloves, eye, and face protection are minimum if delivery is already begun or is complete. If time allows, you definitely want to put on a gown. Might not get the opportunity to do that, but it's something that should be considered. Consider calling for additional resources. For your mechanism of injury or nature of illness, you will encounter pregnant patients who are not in labor, so it is important to determine the mechanism of injury or nature of illness. Do not develop tunnel vision during a call. Falls and necessity for spinal immobilization must be considered. All right, now after your scene size up, the next phase of your assessment is your primary assessment. So form a general impression. The general impression should tell you whether the patient is in active labor or whether you have time to assess and address other possible life threats. Perform a rapid examination. When trauma or other medical problems present, evaluate these first. Assess airway and breathing. Life-threatening conditions with the woman's airway and breathing are usually not an issue during a birth. A motor vehicle crash, assault, or medical condition may cause a life threat. Assess the airway and breathing to ensure they are adequate. Now, because it is that their breathing rate is going to increase, a breathing rate below 20 for a pregnant patient that is close to full term should be concerning to you. They shouldn't have a breathing rate below 20. That's concerning. Circulation, external and internal bleeding are potential life threats and should be assessed early. Blood loss after delivery is expected, but significant bleeding is not. Assess for and treat life-threatening bleeding. Assess the skin for color, temperature, and moisture. Check your pulse, or check the pulse. Transport decision. If delivery is imminent, prepare to deliver at the scene. Ideal place to deliver is in the ambulance or the woman's home. If delivery is not imminent, prepare the patient for transport. Provide rapid transport for pregnant patients who have significant bleeding and pain, are hypertensive, are having seizures, have an altered mental status. Now, the history taking. Obtain a thorough obstetric history. So you have to ask questions about the pregnancy, right? When is the due date? Are there any complications expected? Are there any medical problems that have developed because of the pregnancy? Are you doing your regular clinic visits, right? So a history of the pregnancy is going to be important. Obtain a sample history. Pertinent history should include questions related specifically to prenatal care. Determine the due date, frequency of contractions. So you want the frequency of contractions and you want the length of the contractions. So what you need to do is you're going to put your gloved hand on the fundus, which is the top portion of the uterus, and you're going to feel for when it contracts. When it contracts, you time that period. So you time how long it stays contracted and then relax, and you time the distance between the next contraction. So we want the duration of the contraction and the distance between the contractions. And if the contractions are increasing with intensity, if they are coming less than 2, maybe 3 minutes apart, and they are lasting 45 seconds to 90 seconds or less than 45 seconds with crowning, then you know that this delivery has to take place on scene. So determine the due date, the frequency of contractions, and the history of previous pregnancies and deliveries. Very important. So if it's not their first pregnancy, this delivery is going to be it's not going to be a long delivery. So persons who have had previous pregnancies, the deliveries that come after don't take long. So expect that. The possibility of multiples, and if she has taken any drugs or medication. If her water has broken, ask whether the fluid was green or was it yellow. And was there any unusual odor to it, or was there blood in it, a lot of blood? So ask questions. Ask questions. Secondary assessment, physical examination. Assess major body systems as needed, emphasis on chief complaint, assess for fetal movement. So you definitely need to check for fetal movement. And you need to check the fetal heart rate. You can use a fundoscope, or you can use a decent stethoscope to do that. And the fetal heart rate should be above 100 beats per minute. If it's not above 100 beats per minute, the fetus is in distress, right? And also if you note meconium, that's a sign that the fetus is in distress as well. That's the first stool or waste that the fetus passes, right? That's meconium. It's present. It's an indication that they are in distress. If the patient is in labor, focus on contractions and possible delivery. If you suspect that delivery is imminent, check for crowning. Vital signs: pulse, respiration, skin color, temperature, and conditions, and BP. This is what you want. Be especially alert for tachycardia and hypo or hypertension. Hypertension, even mild, may indicate more serious problems. They should not have a high blood pressure. Reassessment. Repeat the primary assessment, obtain another set of vital signs, check interventions and treatments. In most cases, childbirth is a natural process that does not require your assistance. When childbirth is complicated by trauma, any interventions you provide the patient will benefit the fetus. Communication and documentation will occur in a reassessment phase. If delivery is imminent, notify staff at the receiving hospital, provide an update on the status of the woman and the newborn after delivery. If delivery does not occur within 30 minutes, provide rapid transport. For a pregnant patient with a complaint unrelated to childbirth, be sure to include the pregnancy status in your radio report, the number of weeks of gestation, her due date, any known complications of the pregnancy. If delivery occurs in the field, you will have 2 patient care reports to complete. Might be more than that. Now, the stages of labor. You have 3 stages of labor. So you have dilation of the cervix, delivery of the fetus, delivery of the placenta. When you're studying the stages of labor, you need to think about when the stage begins and when it ends. So stage 1 actually starts with lightning, right? So lightning means the fetus starts to move down into the birth canal. So all of a sudden, the mother is going to be able to breathe better, right? So lightning, the mucus plug is expelled and contractions begin. So lightning, mucus plug, expel, contraction starts, and it ends when the cervix is dilated. So that's the first stage. So starts with the contractions, lightning and contractions, end when the cervix is dilated. As EMTs, you will not check for cervical dilation. So for you, the first stage ends when you can see crowning. So if you see crowning, which is the head of the fetus, or you can see the amniotic sac, then that's the first stage, right? That's the end of the first stage. So as EMTs, you're not going to measure dilation, so you're looking for crowning. Stage 2 begins with crowning. So stage 2 begins with crowning and it ends when the fetus is delivered. Stage 3 begins with the newborn being delivered and it ends when the placenta delivers. And the shortest stage is delivery of the placenta. The longest stage is stage 1. Can be long, it can be shorter in persons who it's not their first pregnancy, but you're averaging 8 to 12 hours or 6 to 8 hours, depending on whether or not it's the first pregnancy or second. The delivery phase, you're looking at 1 to 2 hours, can be 30 minutes. the delivery phase of the placenta, you're looking at 5 to 60 minutes. There can be a precipitous birth, and a precipitous birth means that the entire process occurs within less than 3 hours. Everything happens within less than 3 hours. So again, it is important that when you're studying the stages of labor, you look at when each stage begin and when each stage end. That is important. So the first stage begins with the onset of contractions and it ends when the cervix is fully dilated. This you will not check for in the field, so you're looking for crowning to determine if the first stage has ended. It is usually the longest stage, lasting an average of 16 hours. Uterine contractions become more regular and last about 30 to 60 seconds, and they will increase in intensity. So that is important. If they're having contractions, are they increasing in intensity? Because sometimes they can have what is called Braxton Hicks contractions, which is false labor. Basically, the uterus is practicing for the real event, and these contractions don't increase in intensity. So if it's going up in intensity and the interval is short, then you should be preparing. Labor is generally longer in primigravida. The term gravida or gravida means pregnant uterus. So gravida is specific to the pregnancy. The term para is specific to birth. So gravida, pregnancy, para, birth. If they are a primigravida, it means it's their first pregnancy. If they are a multigravida, it means they have had multiple pregnancies. If they are a primipara, then it would be their first live birth. If they are a multipara, they have had multiple live births. A woman may experience preterm or false labor. This is referred to as Braxton Hicks contractions. You should provide transport for the patient. Can be triggered by stress. And there's a table. Ensure that you focus on that table to identify the difference between Braxton Hicks and true labor. Some women experience a premature rupture of the amniotic sac, so it can rupture prematurely, and the water is expelled and they have what is called a dry birth. Patient may or may not go into labor, provide supportive care and transport. If it ruptures within 48 hours, the delivery must occur. The head of the fetus descends into the woman's pelvis as it positions for delivery. This is what we call descent or lightning. So as I said, they are going to feel as if they can breathe much better now. Now the second stage of labor begins when the fetus begins to encounter the birth canal. So it starts with crowning and it ends when the newborn is born. Uterine contractions are usually closer together and they last longer. The perineum will bulge significantly and the top of the fetus head will appear at the vaginal opening. This is called crowning, and you have to support the perineum to prevent it from tearing. The third stage begins with the birth of the newborn and it ends with the delivery of the placenta. The placenta must completely separate from the wall. So no part of the placenta should be left inside the mother. It can lead to hemorrhaging and it can lead to infection. May take up to 30 minutes. It can be longer than that. If after 30 minutes it has not be delivered, and I would say after 15, then transport. Do not pull on the umbilical cord to pull the placenta out. That's something that you will see being done in the hospital setting. Never do that. So never pull on the cord to remove the placenta. You may cause piece of the membrane to tear or piece of the placenta to tear off. Now, preparing for delivery. Consider delivery at the scene when delivery is imminent, will occur within a few minutes. A natural disaster, inclement weather, or environmental factor makes it impossible for you to reach the hospital. To determine if delivery is imminent, ask the patient, how long have you been pregnant? When are you due? Is this your first baby? Are you having contractions? How far apart? How long do they last? To determine if delivery is imminent, ask the patient, have you had spotting or bleeding? Has your water broken? Do you feel as though you need to have bowel movement? Very important. Do you feel the need to push? To determine potential complications, ask were any of your previous deliveries by cesarean section? Have you had problems in this or any previous pregnancy? Do you use drugs, drink alcohol, or take any medications? Is there a chance of multiple deliveries? Does your physician expect complications? Preparing for delivery. If the patient says that she is about to deliver, she has to move her bowels or feel the needs to push, you should prepare for delivery. You don't want them pushing when they don't have a contraction. Does she have an extremely firm abdomen? Visually inspect the vagina to check for crowning. Once labor has begun, it cannot be slowed or stopped. Never attempt to hold the patient's leg together. Do not let her go to the bathroom. Remember, if you deliver at the scene, you are only assisting the woman with the delivery. We are just facilitators. Whether we are present or not, if that baby is ready to come out, he's coming out. Him or her coming out. We're just facilitators. Preparing for delivery. So your unit should have an OB kit. Your emergency vehicle should always be equipped with a sterile emergency obstetric kit. Patient position. Preserve the patient's privacy. Place the patient on a firm surface padded with blankets, sheets, and towels. And you want to cover the legs and you want to cover the abdomen. You want the pelvic or hip region elevated 2 to 4 inches. You're going to need some paper towel because sometimes feces come out and you're going to have to move that out of the way. You don't want the newborn coming out in feces. Support the head, neck, and upper back. Have her keep her legs and hips flexed with her feet flat and her knees spread apart. Place towels or sheets on the floor around the delivery area. Open the OB kit carefully, put on the sterile gloves. Use the sterile sheets and drapes from the OB kit to make a sterile delivery field. And this is what that is going to look like, right? So as I said, down here, sometimes you want to put some paper towel because As she starts to push, feces sometimes comes out. I need to move that as quickly as possible. We don't want the newborn coming out in the feces. And you don't want to mess up your drip underneath the hip. Delivery. Your partner should be at the patient's head to comfort, soothe, and reassure. The patient will allow it, apply oxygen. Continually check for crowning. Some patients experience precipitous labor. Already explained what that is. The entire process will occur in less than 3 hours. Position yourself so that you can see the perineal area at all times, and you need to support the perineum. Time the patient's contraction. Remind the patient to take quick, short breaths during each contraction, but not to strain. So you want them to push when there is a contraction. When there is no contraction, short breaths. Short breaths. And when you're giving them instructions to push, tell them to push down as if you want to have bowel movement. That's the type of push you want. Between contraction, encourage the patient to rest and breathe deeply through her mouth. Right? Delivering the head. Observe the head as it exits the vagina. Support the head with your gloved hand as it rotates. So remember to support the perineum as the head comes out. Right? You don't want them to overstrain when there is a contraction, so you want them to control their breathing. When the contraction ends, let them get some time to get some oxygen in to prepare. Now, once the head is delivered, the first thing you need to do once the head is delivered, make sure you're supporting it and quickly check to see if the umbilical cord is wrapped around the neck. So look for the umbilical cord. That's the first thing. Once the head pop out, do you see an umbilical cord around the neck? So delivering the head, apply gentle pressure across the perineum with a sterile gauze pad to reduce the risk of perineal tear or tearing. Be prepared for the possibility of the patient having bowel movement. It can happen. And yeah, a delivery can get very messy. Do not poke your fingers into the newborn eyes and fontanelles. Remember that their fontanelles are not fused at this stage, so be very careful. Now, you can see an unruptured amniotic sac. So when you look at the vaginal opening, you're seeing an unruptured sac. If this occurs, then you have to rupture it. Kind of use your gloved finger and puncture the sac. So if the amniotic sac does not rupture, by the time the head is crowning, it will appear as a fluid-filled sac emerging from the vagina. It will suffocate the fetus if not removed. You may puncture the sac with a clamp or tear it by twisting it between your fingers. Clear the newborn's mouth and nose immediately. Umbilical cord around the neck. As soon as the head is delivered, check the neck to see if the cord is around the neck. If it's wrapped around the neck, you need to get it over the head. If it is too tight, then we have what is called a nuchal cord. It's going to strangle the newborn. So we need to clamp it and cut it immediately and unwrap it from around the neck. So as soon as the head is delivered, use one finger to feel whether the umbilical cord is wrapped around the neck. Usually you can slip the cord gently over the delivered head. If not, you must cut it. Once the cord is cut, attempt to speed delivery. Delivering the body. Now once the head comes out, the baby will naturally rotate to the left or the right. Right? So they're going to naturally turn. You don't need to pull on the newborn. The newborn will deliver itself. So once the head is born, the body usually delivers easily. Support the head and the upper body as the shoulders deliver. So all you're going to be doing is going up and down. So once the head is out, is the cord out around the neck? If it is, clear the neck, right? If necessary, you may have to suction. And if you're going to suction, you always clear their mouth first and then suction their nose. So suction the mouth first, then the nose, because they are nose breathers. They rely heavily on their nose to breathe. So if you suction their nose first and there is fluid in their mouth, they will aspirate it into their lungs. Right? Now, support the head will naturally turn. As they push, just go up and down. That's all you're doing. Support and go up and down. And the newborn will naturally deliver itself. So support the head and upper body as the shoulders deliver. Do not pull the fetus from the birth canal. The newborn will be slippery and covered in vernix caseosa. Don't drop them. Now, post-delivery care. If the mother is able and willing, place the newborn on her abdomen so skin-to-skin contact can begin immediately, right? Because they lose heat fast, so you need to make sure that they are nice and warm, cover their head. That's where they're going to lose most of the heat from. Dry off the newborn and wrap him or her in a blanket or a towel. Wrap the newborn so only the face is exposed. Keep them nice and warm. You can pick up and cradle the newborn if local protocols specify. Keep newborn at the level of the woman's vagina until the umbilical cord is cut, and do not cut the cord until it stops pulsating. So wait until the cord stops pulsating. Once it stops pulsating, it means that the newborn circulation has taken over. Their circulatory system has now taken over. And when you're going to cut the cord, it's 4 fingers from the newborn, first clamp, and then 2 fingers above the first clamp, second clamp, and then cut in between. Always keep the head slightly downward to help prevent aspiration. So keeping the head downward will allow any secretions or fluid to drain. Wipe them out with a sterile gauze pad as needed. Once the cord has stopped pulsating, clamp and cut the cord. Obtain a 1-minute APGAR score, which is an assessment tool that we use to obtain their first set of vital signs. So the A is for appearance, E is for pulse, G is for grimace, the other A is for activity or muscle tone, and the R is for respiration. The most points they can get for each area is 2. Right? They will not have a APGAR score of 10 when they just deliver. They will probably gonna have an APGAR score of 7, but as time progresses, they will go up to 10. Now, if their APGAR score is very low, below 7, after delivery, every 5 minutes, an APGAR score should be done for up to 20 minutes. Delivery of the placenta. Your job is only to assist. The placenta delivers itself usually within a few minutes of the birth. Never pull on the end of the umbilical cord. You can help to slow bleeding by gently massaging the woman's abdomen with a firm circular kneading motion. Record the time of birth in your patient care report. The following are emergency situations. More than 30 minutes elapse and the placenta is not delivered. There is more than 500 mils of bleeding before delivery of the placenta. There is significant bleeding after delivery of the placenta. Now, neonatal assessment. So you have a newborn. When the fetus is delivered, it is referred to as a newborn in the first hours of birth. After 24 hours has passed, it is referred to as a neonate until it reaches 1 month. So let's look specifically at neonatal assessment and resuscitation. Follow standard precaution. Always put on gloves before handling a newborn. Newborn will usually begin to breathe spontaneously within 15 to 30 seconds after birth. The heart rate will be 120 beats per minute or higher. It should not be less than that. It's less than 100, but above 60, you need to be prepared to start breathing for the neonate. If it's below 60, they will need compressions. If you do not observe these responses, gently tap or flick the soles of the feet or rub the back. Do not hold them upside down by the legs and slap them, right? Just gently tap the feet, rub the chest, rub the back, keep the head down. That's how we stimulate them. Many newborns require some form of stimulation, including positioning the airway, drying, warming, suctioning, and tactile stimulation. And when we suction, it is the mouth first, nose after, mouth syringe. If they require oxygen, you will not put a device directly on their face. You're going to give them blow-by oxygen, because the oxygen, if it's directly on the face, it can damage their eyes. Hold on. All right, pay close attention to this table, table 33-2, resuscitation for a newborn who is not breathing. Now, keep in mind that the BLS response for an infant, how you do CPR for an infant, it's not the same for a neonate, right? It's not the same. So ensure that you pay attention to that table. To maximize the effects of these measures, position the newborn on his or her back with the head down and the neck slightly extended. If necessary, suction the mouth and then nose. In addition to drying the head, back, and body with dry towels, rub the back and flick or slap the soles of the feet. We want them to make a strong cry. We want a strong cry that will open up the ear passage. That's what we want. Observe the newborn for spontaneous respiration, skin color, and movement of the extremities. Evaluate the heart rate at the base of the umbilical cord or brachial artery, or by listening to the newborn's chest with a stethoscope. Ensure that you warm up your stethoscope before putting it on the newborn. The heart rate is most important measure in determining the need for resuscitation. Pay close attention to the heart rate. Anything less than 60 is going to require CPR. If it's less than 100, you should be thinking about assisted ventilation, right? And you reassess every 90 seconds. Some books will tell you every 30, but no worries. If it is above 100, that's where you want it. So look at your effort at breathing. So more than 100 beats per minute, keep the newborn warm, transport the newborn, assess newborn continuously. If it's within 60 to 100, begin assisted ventilation with a BVM and room air. Reassess the newborn after 90 seconds, and if the heart rate and respirations are not normal, begin to ventilate with 100% oxygen. Continue to reassess the newborn, call for ALS, backup if available, keep the newborn warm. If the heart rate is less than 60 beats per minute, begin assisted ventilation with a BVM, 100% oxygen. Reassess the newborn every 90 seconds until the heart rate and respirations are normal. Begin chest compressions, call for ALS backup if available. If the heart rate does not increase, then ALS interventions might be necessary. But usually, if these measures are good, medication is not needed. If chest compressions are required, use the hand encircling technique for 2 persons, and it is a 3-to-1 ratio. As I said, when you're doing CPR for a neonate, it's not the same as CPR for an infant. So it's 90 compressions to 30 ventilation, right? That's 120 actions per minute. So what you're doing is 1, 2, 3, ventilate, 1, 2, 3, breathe, 1, 2, 3, breathe. So it's a ventilation after every 3rd compression, right? And reevaluate every 30 seconds. Any newborn that requires more than routine resuscitation requires transport to a hospital with a level 3 neonatal ICU. About 12% to 16% of deliveries are complicated by the presence of meconium. Consider quickly suctioning the newborn's mouth, then nose after delivery before providing rescue ventilations. APGAR score, standard scoring system used to assess the status of the newborn, assigns a number value to 5 areas: appearance, pulse, grimace or irritability, activity or muscle tone, respiration. Max they can get is 10, should not get less than 5. Sorry, shouldn't be less than 7. The total of the 5 numbers is the APGAR score. A perfect score is 10. Calculate the APGAR score 1 minute and 5 minutes after birth. And there's a table showing what exactly you're looking for. Pay attention to that. Assessing a newborn, calculate the APGAR score. Stimulation should result in an immediate increase in respiration. If newborn is breathing well, assess the pulse. Assess oxygenation via pulse oximetry and observe for central cyanosis. Request a second unit if the newborn is in distress and will require resuscitation. In situations where assisted ventilation is required, use a newborn BVM. If the newborn does not begin breathing on his or her own or does not have an adequate heart rate, continue CPR and rapidly transport. Now, a breech delivery. Most infants are born head first. Occasionally, the buttocks are delivered first. It's called a breech presentation. Breech deliveries will take longer than normal deliveries, so it's going to take a while. Breech deliveries usually take longer, so you will often have time to transport the pregnant woman to the hospital. If the buttocks have passed through the vagina and the delivery has begun, provide emergency care, you're going to need ALS. Consult medical control to guide you. If only the head remains, you may have to support the body of the newborn, and this is an instance where we have to put our fingers inside the vagina to make a V and support their face so that they are not flat on their face in the pelvic floor, which can cause suffocation. Preparing for a breech delivery is the same as for normal childbirth. Now, I'm not going to go through this type of delivery because it's not something that an EMT would be expected to do. There should be an ALS or above, unless your medical control trusts you a great deal, right? But you can review it in your PowerPoint slides. That's something I'm going to go over. Now, this part is important. Right? So if the majority of the baby is out and the head remains, the head is almost always face down and should be allowed to deliver spontaneously. Right? Make a V with your glove fingers and position them in the vagina to keep the walls from compressing the fetus airway. You may have to do that. Other complication, limb presentation. On rare occasion, the presenting part of the fetus is a single arm, leg, or foot. It's called a limb presentation. And a fetus with a limb presentation cannot be delivered in the field, so surgical interventions are necessary. Transport immediately. If a limb is protruding, cover it with a sterile towel. Never try to push it in or pull on it. Place the patient on her back with her head down and pelvis elevated. Prolapse cord. So the umbilical cord may be at the vaginal opening. The risk is the baby can create compression on the cord, cutting off their circulation supply. Prolapse of the umbilical cord must be treated in the hospital setting. The umbilical cord comes out of the vagina before the fetus. 2 EMTs may be needed around the back for this because one need to create to relieve pressure off the cord. So this is another situation in which we would put our fingers inside the vagina to keep the head of the umbilical cord. The fetus head will compress the cord and cut off circulation. Do not push the cord back into the vagina. Place the pregnant woman supine with the foot of the cot raised higher than the head, with her hips elevated or in the knee chest position. Insert your glove hand into the vagina and push the fetus head away from the umbilical cord. Transport rapidly. Spina bifida. Developmental defect in which a portion of the spinal cord or meninges may protrude outside of the vertebrae. Seen on the newborn's back, cover the open area of the spinal cord with sterile, moist dressing. Maintenance of body temperature is important when applying moist dressing. Multiple gestations. Twins can occur once in every 30 births. Always be prepared for more than one resuscitation and call for assistance. Twins are smaller than single fetuses and delivery is typically not difficult. About 10 minutes after the first birth, contractions will begin and the birth process will repeat itself. The second one is usually born within 45 minutes of the first. Now, continuing with multiple gestation, the procedure is the same as that for a single fetus. There may only be one placenta or there may be two placenta, depending on whether they are identical or fraternal twins. Record the time of birth of each twin separately. Twins may be so small that they look premature. Handle carefully and keep them warm. Premature birth. A normal full-term single newborn will weigh about 7 pounds at birth. Any newborn who delivers before 8 months, 36 weeks, or weighs less than 5 pounds at birth is considered premature. A premature newborn is smaller, thinner, and the head is proportionally larger. The vernix caseosa will be absent or minimal. There will be less hair. Premature newborns require special care to survive, often require resuscitation efforts which should be performed unless it is physically impossible. With such care, premature newborns as small as 1 pound have survived and developed normally. Post-term pregnancy. Pregnancy lasting longer than 42 weeks. Fetuses can be larger, sometimes weighing 10 pounds or more. Can lead to problems with the woman and fetus, a more difficult labor and delivery process. Problems include increased chance of injury to the fetus, increased likelihood of cesarean section. Woman is at risk for perineal tears and infection. Post-term newborns have increased risk of meconium aspiration, infection, and being stillborn. Newborns may not have developed normally. Fetal demise. You may deliver a fetus who died in the woman's uterus before labor. Onset of labor may be premature, but labor will progress normally in most cases. If an intrauterine infection caused the demise, you may note a foul odor. Do not attempt to resuscitate an obviously dead neonate. Delivery without sterile supplies. You may have to deliver a newborn without sterile OB kit. You should always have eye protection gloves and a mask with you. Carry out the delivery as if sterile supplies were available. Use freshly laundered sheets and towels. Wipe the inside of the newborn's mouth with your finger. Do not cut or clamp the umbilical cord. As soon as the placenta delivers, wrap it in a clean towel and transport. Keep the placenta and the newborn at the same level and keep the newborn warm. Oops. Okay. If bleeding continues after delivery of the placenta, continue to massage the uterus. Check your techniques and hand placement if bleeding continues. Excessive bleeding is usually caused by the uterine muscles not fully contracting. Cover the vagina with a sterile pad. Change the pad as often as possible. Do not discard any blood soaked pads. Administer oxygen, monitor vital signs, and transport the patient immediately. Postpartum patients are at an increased risk of an embolism, most common pulmonary embolism. Results from a clot that travels through the bloodstream and becomes lodged in the pulmonary circulation. Consider when a woman complains of sudden difficulty breathing or shortness of breath following delivery. And that would be the OB chapter.